Hi, everyone. My name is Chase Morey. I'm a fourth year medical student, and welcome to this anatomy imaging walkthrough. In this podcast, we'll review the structures from your ID list for the upper respiratory tract using mostly CT imaging. As a frame of reference, the upper respiratory tract in this case is going to include the respiratory anatomy from the nose to the vocal folds. Let's first start by laying our foundation of the anatomy with the bones of the skull and the nasal cavity. The skull is a very irregularly shaped object, and it's filled with air-filled sinuses. And when you're looking at it on CT, which takes a lot of straight slices, either in coronal, sagittal, or axial views, it can be hard to appreciate the actual shape of these skull bones. But the way I'm going to present it is with a coronal window on the left and the sagittal window on the right that has this green tracker marker to show you exactly how deep our coronal window will be. So whenever you see me scrolling, you can always reference this green tracker marker as it moves deep or superficial in the scan. So as I scroll deeper into this scan, we want to start at the top here. This bone is the frontal bone. It's the bone you think of when you think of someone's forehead. It's immediately superior to the orbit. So here's the patient's right eye. And within the frontal bone is this air-filled sinus. This is the frontal sinus. You can see it really well on the sagittal window. Just below, inferior to the frontal sinus, are these anterior protruding bony prominences that almost look like they're serving as a patient's nose bridge. These are nasal bones. On the coronal view, just below the nasal bones, is an opening to the nasal cavity. This is the anterior nasal aperture. The anterior nasal aperture is formed superiorly by the nasal bones and laterally by the maxilla, which are the bones that sit just below the orbits. You have a right maxilla and a left maxilla, which I can catch a glimpse of a little bit better here. Switching to a coronal image for 1 second, I want to demonstrate the boundaries of the different bones in this region of the face. Up top is the frontal bone, and within it is the frontal sinus. Just below the frontal sinus are the nasal bones. If you look closely, you can appreciate these hypodense lines separating the nasal bones from the frontal bones. Also, laterally, there are hypodense lines separating the maxilla from the nasal bones. So if you draw this out, these are the nasal bones in this coronal image. These are the maxilla, and then this is the frontal bone. Another thing to point out is this thin bony sheet within the nasal aperture. This is actually the upper part of the bony portion of the nasal septum, aka the upper part of the bony septum. Let me draw an arrow. The upper part of the bony septum is different from the nasal bones. In fact, it's part of the ethmoid bone. The difference between the two is the nasal bones are externally bordering the nasal cavity. They're serving as like the nose bridge, whereas the bony septum is going to appear very thin and sheet-like, and it's within the nasal cavity. Returning back to our coronal and sagittal views to illustrate the bony septum, it is harder to appreciate any sort of division in this area, but you can imagine that the nasal cavity outlined here has the bony septum within it and the nasal bones external to it. On our sagittal view, you can also see here are the nasal bones. If I scroll a little bit further, here is the upper portion of the bony septum. I mentioned earlier that the upper portion of the bony septum is contributed by the ethmoid bone. The inferior portion of the bony septum is actually another bone, a separate bone called the vomer. And if I scroll deeper, looking at the coronal, you start to see within the nasal cavity a bony prominence protruding superiorly. This is the inferior portion of the bony septum, which is contributed by the vomer. The entirety of our septum is not made out of bone, though. So as I scroll more superficially, you'll see that within the nose, there's this cartilage, which is less bright than a bone would appear, but more dense than air appears. So these are the nostrils, and in the middle is the septal cartilage. So the nasal septum is made up of septal cartilage and a more bony septum posteriorly. Scrolling a bit deeper into the nasal cavity, you start to notice these beautiful swirls along the left lateral nasal wall. These are the superior, middle, and inferior nasal concha. These are bony projections that increase surface area and humidify the air that we breathe in. Below each concha is a corresponding meatus. The meatus is the groove or hallway under each of these shelves, these bony shelves. These areas are very important areas for drainage of sinuses and ducts within the face. The inferior meatus is actually where the nasolacrimal duct drains. Scrolling a bit more superficially, you can see the nasolacrimal duct connecting the patient's eye to the inferior meatus. This is a great clinical connection, giving us an explanation for why your nose may run when you cry. You can also see this connection on the sagittal view. Here you can pick up the nasolacrimal duct connecting the orbit to the nasal cavity. If I scroll one slice deeper on our coronal image, you can pick up an ostium within the maxillary bone connecting this sinus to what's actually the middle meatus. Here's the inferior concha with the inferior meatus. This is the middle concha with the middle meatus. You can't appreciate the superior concha or meatus in this slice. But this sinus here is the maxillary sinus within the maxillary bone. The maxillary sinuses are your largest sinuses, and they occupy the cheek area just below the orbits. I always found that the maxillary sinus draining in this fashion compared to the nasolacrimal duct draining in this fashion forms an X, being very counterintuitive in my studying, but it's something that does get tested from time to time, so I wanted to emphasize it on the imaging. So here's the maxillary sinus draining into the middle meatus versus the nasolacrimal duct draining into the inferior meatus. To round out the nasal cavity and the sinuses, I'm going to return our sagittal view to the midline, approximately. And if you hallucinate a little bit, you may be able to appreciate this hypodense line dividing the frontal bone from a bone immediately posterior to it, which is the ethmoid bone. And the ethmoid bone is extremely porous. It's almost like a sieve at the midline. It has these micropunctures here that allow aromas to enter the nasal cavity and send impulses via olfactory nerves into the brain. That's what gives us our sense of smell. This sieve-like portion of the ethmoid bone is the cribriform plate. As I scroll a bit more laterally, in the ethmoid bone, it's very porous. These are the air cells of the ethmoid bone, also called the ethmoid sinuses. On coronals, the ethmoid sinuses are the sinuses immediately medial to the orbits. I'll scroll the coronal images a little bit deeper and return our sagittal back to midline. So this is the ethmoid bone with the cribriform plate. Immediately posterior to the ethmoid bone, you start to see the sphenoid bone. And within the sphenoid bone is this large air pocket. This is the sphenoid sinus, which is the deepest sinus that we can make out. Just below the sphenoid bone, we can see that the bony septum ends. And what this tells us is that we are now exiting the nasal cavity. Knowing that the anterior entrance to the nasal cavity was called the anterior nasal aperture, what do you think the posterior exit of the nasal cavity should be called? The posterior nasal aperture, right? That makes the most sense. But a more common term that you'll hear used, especially on clerkships or maybe even on tests for the posterior nasal aperture, is the choana. And there are two choana. There's a left and a right choana. You should familiarize yourself with the term choana because there's a high yield phenomenon commonly tested during your clerkship years called choana atresia. Anytime you hear atresia, you should think of the absence or abnormal opening of a structure that's usually patent. With choanal atresia, one or both of these holes aren't open, they aren't patent, and it's not hard to understand why this would cause breathing problems in a young child or a baby. Just deep to the choana, we're exiting the nasal cavity, but we're entering the pharynx. More specifically, we're entering into the superiormost portion of the pharynx, the nasopharynx. The pharynx is subdivided into three parts. The nasopharynx, which is posterior to the nasal cavity and extends to the level of the soft palate, which is the soft part of the roof of your mouth. Below the nasopharynx is the oropharynx, which is posterior to the oral cavity and extends to the tip of the epiglottis, which if I scroll here, this is the epiglottis here. So the oropharynx is roughly divided right there. Below the oropharynx is the laryngopharynx, which is posterior to the larynx. It begins at the tip of the epiglottis and it extends down to the level of the cricoid cartilage. So you can't see it here on this image yet, but we've talked about it in a previous lab, and I'll show you later in this lab. Here's a cadaveric image from KinHub that denotes the subdivisions of the pharynx, the nasopharynx, oropharynx, and laryngopharynx. So those are the levels of the pharynx, and you can distinguish these levels nicely on a sagittal CT. Another thing that you can see on the sagittal CT is the retropharyngeal space. This is a potential space between the pharynx and the cervical vertebra, and it's highlighted clinically because it can spread infection from the head and neck into the thorax. Also, when it gets infected, the space can expand and cause obstruction of patients' airways, sometimes requiring the patient to be intubated. Before we move on from the nasopharynx, there are some structures that I'd like to show you, and it requires adding an additional axial view, which I have here now on the right. So I've scrolled this axial view to about this level, and we're going to hit on the nasopharynx here. In the axial view, whenever you add a new view, it's always great to orient yourself to try to find the nasopharynx. So we can start at the top. This is the patient's nose. This must be the septum, the septal cartilage, and then the bony septum. These would be the maxillary sinuses. We know that when the septum terminates, that means we are exiting the nasal cavity and entering the pharynx. And we know we're at the level of the nasopharynx because we're above the soft palate of the mouth. So that means this area must be the nasopharynx. What we're interested in the nasopharynx in this axial view is actually the outline of this area. The two indentations here on the lateral wall of this outline, these are the openings of the pharyngotympanic tubes, also known as the eustachian tubes. So these indentations are actually connecting to long tubes that extend from the nasopharynx into the middle ear. In addition, this bulging mucosa immediately posterior to the openings is the torus tubarius. The posterior wall, the deepest wall of this outline, is the pharyngeal tonsils, aka the adenoids, whenever they're enlarged or infected. Here I have a screenshot of an axial slice where the torus tubarius and the openings of the pharyngotympanic tubes are much clearer compared to the last image. So once again, this is looking at the nasopharynx in this area. And these indentations are the openings to the eustachian tubes, the pharyngotympanic tubes, whereas the posterior bulging of the mucosa is the torus tubarius, and the posterior most wall are the pharyngeal tonsils, but whenever they're large or inflamed, you can call them the adenoids. You may wonder why it's important to study these structures in this weird view, which is a valid question. Well, in this fossa right here, in between the torus tubarius and the pharyngeal tonsil is actually the most common site for nasopharyngeal carcinoma to develop. And do you remember what virus is associated with nasopharyngeal carcinoma? The answer is EBV. In a previous lab, we talked about the thyroid and cricoid cartilage. So for this lab, I'm going to present the larynx from a little bit of a different perspective, just to give you some more exposure to how you may see imaging. This coronal image on the left is showing a slice of the anterior and superficial neck. To orient you, if there was a tracker line in the sagittal view, it may be somewhere like right here. On the coronal view, the first thing that I want to point your attention to is the hyoid bone. And immediately inferior to the hyoid bone is this butterfly-shaped, less dense than bone. That's the thyroid cartilage. Here, like I said, it's shaped like a butterfly, and it may be coming to a point in the midline. That's representing the patient's Adam's apple, or more formally known in anatomy as the laryngeal prominence of the thyroid cartilage. If I scroll a bit deeper on this coronal view, you get a great perspective of mucosa inserting itself into the patient's airway. These mucosal folds are actually the vocal folds. The superior vocal fold is also known as the false vocal fold. The inferior vocal fold is also known as the true vocal fold. The false vocal fold can also be named as the vestibular fold, and the true vocal fold can also be known as just the vocal fold. That was confusing for me to remember when I was studying anatomy, but from top to bottom, it follows alphabetical order. So the false is above the true, and the vestibular are above the vocal. This space in between the true vocal folds is the rima glottis. If I scroll a bit deeper on this coronal image, we start to see the thyroid and the cricoid cartilages. Here's roughly where the tracker would be on the sagittal images. On the coronal window, we can see this is the thyroid gland taking up the iodine contrast in this study and giving it this bright appearance. Immediately superior to the thyroid gland, you can see the cricoid cartilage. And superior to the cricoid cartilage, we're getting a very interesting view of the thyroid cartilage, which is really bright in this image. It looks much brighter in this slice compared to when I was showing the more anterior superficial slice of the thyroid cartilage, because the cartilage within your larynx actually ossifies as you age. So this posterior part of the thyroid cartilage is nearly as dense as bone. Looking back here at the sagittal view, I want to once again point out that you can see a little bit of cartilage here behind the airway, posterior to the airway, and that either corresponds to the thyroid cartilage or the cricoid cartilage, since we're above the thyroid but below the hyoid bone. And if you had to guess what this piece of cartilage is corresponding to posterior to the airway, which one would you choose, either thyroid or cricoid? That posterior component is part of the cricoid cartilage. And I want to remind you, this is the only cartilaginous structure that completely encircles airways. The thyroid cartilage and even tracheal rings are C-shaped without any posterior connection. Finally, on this sagittal view, I want to point out, I talked about it earlier, but the epiglottis. Here's the epiglottis. It's this leaf-shaped piece of cartilage just superior to the larynx, deep to the hyoid bone and within the airway. The epiglottis can also be evaluated on x-ray. Here on the left of the screen, I have a normal lateral neck x-ray with the patient extending their neck. You can see this is the hyoid bone, and just deep to the hyoid bone is the epiglottis. So I can outline it here. Notice how it's nice and thin in this x-ray. Posterior to the epiglottis is the laryngopharynx. Here's their retropharyngeal space, and then the cervical vertebra. Compare this image to the epiglottis here on the right. So here's the hyoid bone. This is the epiglottis. It's really thick and edematous. This is called the thumbprint sign because it looks like a thumb. The thumbprint sign is seen when the epiglottis is inflamed or infected. And the diagnosis here is epiglottitis. Epiglottitis is very dangerous. It's seen mostly in the pediatric population, and the epiglottis gets so inflamed and edematous that it can obstruct a patient's airway, requiring urgent intubation. That wraps up the upper respiratory tract anatomy ID list. Hopefully this helps reinforce how these structures relate in 3D space and how to find them on imaging. As always, think about both the anatomy and why it matters clinically. Let me know if you have any questions or suggestions for future walkthroughs, and I hope you guys have good luck studying.